for being and for letting us even record it for archival purposes. In fact, we try and record all these dialogues going back some ways. You will notice, if you've been looking carefully, this is dialogue number 206 in the 31 years that we've been doing this. It matters to our institution. We think we've been having, we've been able to have some really good intellectual fun over, well, took us 3 decades to figure it out. My name is Ken Goodman. I direct the Institute for Bioethics and Health Policy. I am grateful that you all are here. As you know, our special speaker today is Jodyn Platt from the cold Midwest, University of Michigan. She, like many of us in the world of ethics and information technology, is excited about the interesting ethical, legal, and social issues that occur when we use information technology in healthcare. She's associate professor in learning health sciences, where you're going to talk a little bit about what it means to be a learning healthcare system. And if not, I will have a friendly amendment at Michigan, and has worked for many years, one of the leaders in the field of those interested in ethics and health information technology. Dr. Platt, the floor is yours.
Great, thank you. I'm really happy to be here. I'm glad that you all are here in the room and out there, wherever you are. If you have trouble hearing me, let me know. I don't know what, like, if I'm using my indoor voice, my outdoor voice, or something in between.
I've actually paused. Can you all hear okay?
Actually, it's a little bit weak. Can we increase the volume, please?
Yes,
So where's the microphone?
right here.
Put that right. Oh, is it that thing now?
No. That's in my model.
What about now? Is it getting better?
You are coming up great, Ken, but our speaker is a little bit weak, so I'm not sure.
Is that better?
Much better.
Okay, good. Great. So if that changes, just pipe up. I also realize that there's dialogues in research ethics, so I'm happy to stop at any point along the way and have a dialogue about things. But otherwise, I'll just sort of power through. Oh, there we go. Okay. So the context in which I'm speaking is, Ken talked a little bit about this, but there's a lot of health information technologies out in the world, and they're expanding. And clearly, sort of the obvious case is the electronic health record, which has sort of grown exponentially over the last 10 years. We have consumer health apps that are walking around on our phones, and we're investing as a country and as a world billions of dollars in this new form of technology. I also think it's important to realize that, particularly in the United States and other places where the EHR is only 10 years old, it's only 10 years old. So it's actually a very, very early kind of technological innovation. But we're moving towards increasing interoperability, the ability to share data, and we're moving sort of at disparate paces. So there are, academic medical centers that are very good at sharing health information, and community hospitals that are not at all. So, okay. One of the aha moments for me, and this is also came up, I'd say, very much in the context of the learning health system, where it was like, okay, we have data, we want to be able to learn from it. And people were like, okay, if you want to learn from it, I came from sort of a research ethics background, and I was like, okay, well, where's the informed consent? They're like, oh, no, we're doing quality improvement. So that's a different animal. And the aha moment was, for me, was, okay, we actually are sort of deciding post hoc what our data is being used for. So traditionally, we have an intended reason for collecting information about people, whether that's research or quality improvement or even public health. And then we have a set of policies that define how we can use that information. And then we have, following a prescribed set of rules. And with these new information technologies, we can now collect the data and decide later how we want to govern it. So there's sort of a lifelong set of questions around what are the appropriate policies. And if we don't know, how do we change what we have to either innovate or use existing structures that might work better? There's a number of policy kind of oriented questions. There's also, that goes along with this, sort of the ethical questions. So if are we following sort of the traditions and things we know about research ethics? Or are we really talking about, this is a public health sort of everybody needs to benefit from it. We don't need informed consent because there's a common good that we're all going after. And again, here, there's some opportunities to innovate, to bring new people in. And the health information technology also brings in people that have never really been part of the healthcare conversation. So health IT developers who are in Silicon Valley don't know about the Belmont principles. Nor is it clear to them that they need to, but arguably, I would say that they do. But there are sort of a number of questions, sort of what are the ethical values and frameworks that should be a part of the conversation. And so there are a number of what's sort of happening now is we're beginning to see in the context of AI and health information exchange, a lot of ideas and principles about what we think we should be doing. So the Office of Science and Technology Policy out of the White House recently put out a blueprint for an AI Bill of Rights, where they're basically saying, okay, people should be able to be part of AI systems that are safe and effective, that prevent systematic algorithmic discrimination. Data privacy should be of utmost importance, but also people should know and have access to an explanation about how their data is being used, and have real human alternatives and consideration of feedback. So if they're part of an automatic system, there's a person that they can call. The person is real, then call me. There are also a number of sort of guidelines and guardrails that are sort of, coalitions. Again, people's trying to find that balance between regulation and best practices. And again, we don't quite have those best practices yet, but hopefully we can get there in a way that's sort of evidence-based. So, and eventually we will have regulation. And again, they're sort of popping up as ideas, but have yet to be passed. So for me, and sort of the work that I tend to do is I'm often looking at sort of what health policy is. And we were talking a lot about mentorship the last couple of days. Toby Citron was one of mine, and he talked very often about the fact that health policy is a determination of a course of action that blends professional knowledge with community values. And he held that very strong to heart, and it was very sort of a part of who he was and what I learned about what health policy is. And he extended those community values very much to the patients and the public that healthcare serves ultimately. Another sort of key theme in the work and the research that I'm going to share with you today is that of trust. And again, I got my start from in Michigan, looking at the ways in which newborn screening blood spots suddenly became a resource for research. But again, they sort of walked through the public health door and not through the research door. So they were basically changing the social contract for folks. And when we went out and started to speak with the community to understand sort of what the appropriate policy could be, these were we heard things, we heard trust as a major issue. This will end as a trust issue. And if you're telling me we're taking specimens now, what else is being taken without our knowledge? And again, sort of also very much enmeshed with questions of race and equity. Can I truly trust you African American people in this class? No, I want involvement in information. Which brings us to sort of the research and sort of ideas that we're going to talk about today. And so mostly the work that I do is at this sort of intersection of policy, what we might do informed by ethics and values of various stakeholders. And for me, that's mostly the public and patients, but increasingly is other people as well, because it's a conversation between all of those. And most of what we're going to talk about today is in the context of first data, and then increasingly the health analytics space. Looking at this question of, are we ultimately creating systems that deserve the trust of people and institutions, and how can we better align policy with public expectations and values?
Does it need to be drawn, be explicit, those plugs don't fit?
Good job, yes. There you go. And not only,
That's a US plug and an EU plug.
yes, it's not even just a question of the number of holes. Good catch. All right. Hopefully we can do better than that.
I can see that.
All right. So we're going to go through some research that answers 3 questions. First is, would the public like to be notified about data sharing? And the answer is yes, but we'll show some different sort of permutations of that. So given that they'd like to be notified, then the question is sort of how can we build systems that are better about notifying people about data sharing? And then ultimately, then what does it matter what types of data are being shared? And I'm going to show some research where we're looking at genetic data versus EHR data, and sort of how people would think about how you might govern those different data types differently. So yeah, the answer is yes. And one of the ways we've studied this in a couple of different ways, mostly doing survey research, but what we asked most recently was a series of 12 questions that asked people whether they would like to be notified about university researchers, quality analysts, or commercial companies using their identified or de-identified health information for biospecimens. And so the first thing we sort of found from this is that yes, people would like to be notified about all of these different combinations of things. So they want to know about all of the different users, whether it's identified or de-identified, and whether they're biospecimens. They answered the questions on a 4-point scale of not true to very true. So anything over 2.5 is going to be a yes, and all of them are over 2.5. They did seem to have people have a stronger preference about identified versus de-identified data, and that makes sense. Interestingly, they did not differentiate between quality improvement and research. Those numbers are pretty much in alignment. Nor was there a difference in the way in which people were thinking about health information versus biospecimens. So again, sort of from a policy perspective, it's sort of like an oh whoops or oh no, or let's see how we can do this better. But we've also done a fair amount of research to try to understand how people would like to be notified. And what I'm going to show you now are some results from a public deliberation that we conducted over the last couple of years. I think the dates will come up in a second. We did a couple of them in person pre-COVID and 4 of them during COVID virtually. But basically what a public deliberation is a community discussion that brings people into the process of somehow making a decision and problem solving. They're a lot like focus groups, people who are sort of hardcore deliberation researchers or proponents might sort of balk at that statement, but it's adjacent to focus groups. You just spend a lot more time with people, so you have time to provide the education that goes along with an informed discussion. So the way we went about this was we had an initial survey and registration process, sort of beginning to form relationships with participants. And then we had basically 2 sessions with people. One is sort of a large group with it, so providing education and Q&A, and then followed by small group discussions, another large group, another small groups, and then final debrief and following. Another sort of key component of deliberative processes is ultimately sort of communicating with policymakers and returning results to participants. So we talked about notifying patients about data sharing and looking at the context of precision oncology in particular, and provided people with ultimately 2 scenarios. One that sort of focused on how and why health information is shared in the context of care and population health, and talked about both sort of how data is collected over the course of treatment, but also how that information is then shared with hospital registries and provided to sort of national surveillance. And then we came back and I'll show you that sort of scenario 1 in a second. The second scenario also included in the context of data sharing, the relationships that many health systems have with commercial companies that make genome sequencing possible and the sort of advanced diagnostic possible. So the first scenario was, a woman named Florence went in, had tumor, had it sequenced, and received sort of treatment for her cancer. And then we sort of tell the story of her data that goes along with it, and we ultimately gave people 4 different options for how they might want to be notified, in addition to the current practice of just sort of providing a HIPAA statement and the form that you say that says that you were notified about HIPAA rules. So there's always an option to sort of no change to the current policy. The additional phrases we gave people were saying, okay, we can just put up signs in the clinic that say something very straightforward, like your health information is being shared. If you'd like more information, call this number. Second option was to actually sort of actively notify people through a text or an email that data sharing is occurring. And then just the third option here was to put information in the patient portal. So I'm going to show sort of both the rankings for the two scenarios and then some of the dialogue that went into making those decisions. But it can be fun before I show the first set of rankings, like to think about what you think people choose as the first option. The portal was the top option. No change was the last. And then there was some variation around the other two. But people in general, and we'll talk about this in a second, like they thought that the portal was kind of a nice, an easily accessible place for people that are already receiving patient care. The second scenario then described also the way in which a biopsy may be sent to a commercial company and allowed people in this particular case to again have disclosure about health information sharing with commercial partners via the patient portal. They could, or we kept the sort of text email option as a possibility in the scenario B. Option 3 was to be able to opt out of commercial data sharing. So you still have, all of the care that you receive, but you wouldn't necessarily need your data to be kept by that company. We also raised the question of whether patients should be paid for their health information and their biospecimen, as that's sort of something that's out there as in certainly academic circles as sort of an option. And a few startups have tried this, and then obviously sort of no change is also an option. So again, here, the top choice was the patient portal. So, and again, we had some here followed by followed by opt out, right? So it turns out that opting out is a really important feature of sort of participating in the health information enterprise, which again, as we get more and more data and more complexity in the health information ecosystem, I think becomes more and more difficult to guarantee, but remains sort of an important thing for patients.
Jodyn, let me interrupt and ask, so for some of them, the numbers between Detroit and Ann Arbor
Yep.
are significant. Is that something that you have? Is that here in Miami, of course, we're one happy homogeneous community.
Yes, that's a great question. I love the happy homogeneous. Yes. Michigan is, I don't know whether they're happy or not, but they're highly segregated. We're thrilled, right? It's super fair. So Ann Arbor is, well, it's a college town, so it has the demographics you would expect in a college town. Detroit is about 85 or 90% African American, and the rest are sort of. Clare County is a rural community in the middle of the state. Northern Michigan is rural, also way up north. And Grand Rapids is sort of a new urban community, I'd say, sort of increasing. So, yeah, and in general, except for Detroit, Michigan is very white. Yes. But I think for the most part, the differences are not as stark as you could find that thing. There's a fair amount of confluence, there's agreement on things. Yeah. Okay. So opt out is important. Payment, people didn't really like at all. They thought it was confusing, and they also felt like they were going to pay for it in the end. Right. So you can give me my $5 now, but my insurance may go up by 50%, whatever. But so it wasn't a credible alternative. So I'm going to go through now again, sort of some quotes, some sort of specifics about what we heard and sort of our key findings from the overall deliberations. So for the most part, what we heard from folks was that people want policies that are convenient, or don't increase burden on the patient. So we really force people to, or we tried to force people to rank preferences, but really, people also really wanted all of the options all at once. So we heard things like, not everyone is getting information or has accessibility to that information as well. It needs to be a point where it can reach everyone, regardless of how they're able to access it. So again, a sense of, we need something for everyone, sort of a precision approach to how we're communicating. For me, I use the portal quite a bit, so access is going to be the best way to reach me. And other people saying that they prefer phone call, but it's the digital age and texting is the next best thing because it's easier. Grab my phone, read a text, and keep moving. So nothing too burdensome, but also something that will get people where they are. For the opt-out option, most people saw both the benefits and the cost to allow an opt-out, and the notion that, for some people, it's like, I don't want people to opt out. I think it will stunt the progress of medicine, and I want to take advantage because we all benefit from that. So some people being really okay with that. Other people feel like my gut tells me that everybody should have the right to opt out. My brain tells me that if we have that option, it's going to be too much limits to everyone. And other people saying that, I chose opt-out because I'm in the opinion that you should always be able to make your own decisions on what happens and what doesn't happen with your healthcare information. And then the sort of my body, my choice, the sort of really sort of tangible and human connection to their information and their biospecimens. This was pre-DOT, that matters, but it was. And ultimately, change is desirable. I feel like something should change is sort of the simple way of saying it. And the other way that we heard quite a bit was who understands or wants to sit there and read the HIPAA form, it's lawyer language. Even as a person in the medical field, I don't understand half of what they bring. So accessibility. So then we'd be able to sort of, with these earlier studies sort of under our belt, we can then sort of begin to put different combinations together and see how and under what circumstances different types of data policies essentially can go together. And does it matter when we're talking about genetic information or EHR information? So for this, we did a follow-up survey of, again, about a couple thousand people using the University of Chicago NORC Amerispeak panel, so pretty good number of people. And we did something called a conjoint analysis, where we could basically do A/B testing for a series of policy options. And we varied, I think we varied 2 at a time, kind of like what you can see here. And on the next slide, you'll be able to see all of the options for each of those attributes. So we asked people whether they would like to learn about how their health information is shared from the patient portal, whether they have a form that they receive when they arrive at the hospital, that's sort of the status quo, via text messages or via signs displayed at clinics and hospitals. We asked people whether they had a preference between shared data being identified or de-identified, whether the hospital can make decisions about sharing information with commercial companies, or if it really lets people opt out of that sharing. We asked whether it makes a difference between biospecimens that are kept indefinitely or if they're destroyed after 3 years unless you give permission. And then we also thought maybe it matters why they're sharing information. So does it matter if they're sharing information to develop a new product or service, new treatment, or to evaluate the accuracy of genetic or diagnostic tests? So we split the sample into 2, and for some people, the context was genetic information, the other half, the context was EHRs. And what this set of data tells us is that there is a strong preference between identified versus de-identified. Not much of a difference in the first bucket in terms of different types of health information sharing. People really like they prefer opt-out people want to be able to opt out. They don't really like the idea of having the hospital make decisions on their behalf. There's a strong preference for opting out or for genetic versus EHR data. So if there's going to be a difference, it would be along those lines. And there is not a big difference in preferences for how long data biospecimens are kept, nor for sort of how what the different purpose is, at least along these 4 dimensions, 3. So what the sort of collection of information for us is telling us is that, moving beyond the status quo is going to be important. So we sort of need to catch up with the technology. Policies need to catch up with what we're able to do. The people want to know, but also people are going to be different. The portal is probably a good start, but isn't the end of the story. Opting out is a persistent preference, but we just mentioned this. What does it actually mean for patients to be in control of their data? That's a big, huge question that I would love to hear your thoughts about. It seems like the public is not ready for the health system to be a sole decision maker. And so what type of governance actually is appropriate? Can there be a trusted broker? And who is that trusted broker on behalf of patients? Or is it really something that people need to be able to run themselves somehow? And we also see sort of big differences between identification and de-identified data and biospecimens. And clearly that's a question mark, because the more data we have, the less we can sort of guarantee that de-identification is a real thing. So those are some of our findings with respect to sort of data, sort of, how people feel about data and what kinds of policies might go along with it. And we're starting to sort of take that sort of methodology and set of practices and turn it towards these newer questions related to AI, which seems to be everywhere these days. And here the policy problem is a little bit different, but similar, in that, we have a digital world that was ultimately, even with the best data that we have, will mirror the challenges and biases and inequity in our three-dimensional world. And so we're currently working on a grant right now that will do the sort of survey, qualitative deliberation thing, and then a follow-up survey at the end, with the ultimate goal of being able to sort of develop consumer, patient, public-facing product information labels or notification practices that really sort of, in some ways, sort of uphold those core principles of the AI Bill of Rights. So we're currently developing a survey about, trying to understand how we talk to the public about AI in clinical context, trying to identify the appropriate examples. We've done a number of focus groups with our CTSA community engagement core to understand what are the appropriate sort of corollaries, and they've come up with most of these, whether that's GPS, stock market, or targeted ads. We're also surveying and interviewing patients, the public, and experts about what they understand about different terms. So do we talk about AI as artificial intelligence? Is smart technologies a more accessible term? Machine learning is out there, and predictive models are also out there. In some of our preliminary interviews, we've spoken to about 10 patients in the public, and then about 20 other folks right now. And for the most part, smart technologies for the public seems to be the most accessible term. After that, AI seems to conjure up images of robots and limbs. Predictive models is slightly foreign, but people understand the words, and so can make pretty good educated guesses. And machine learning just doesn't make sense.
Well,
Machine learning isn't intuitive, it doesn't work. Yeah. And again, based on those conversations, and even those among our research team, the focus really needs to be for AI on what AI does and not so much what it is, because even the experts don't really know. And so these are the kinds of images we're starting to conjure to sort of communicate what AI is doing and the types of data, the sort of notion that data is an integral part of how decision making is happening. And then this is an example of a product information label that we developed a few years ago now. It was published last year, but this particular sort of label would be more clinician focused than the one that we're proposing for the public and patients. But you can see here the kinds of information that we heard might be important for clinicians to know. So who's using it, who developed it, how was it developed, what's its purpose, and then also sort of trying to integrate in these sort of communications and notifications, model cards, whatever you'd like to call them, some notion of how this is impacting or is integrated with inequity and improving health equity. And then looking then to sort of how do we integrate what we know and what people care about into appropriate governance models. The FDA is trying to do this, but again, they're under resourced to be able to keep up with technologies that change with new data. Okay. So we're starting to look ahead. We're going to keep going forward, but we've got, a place now where we have more questions up in the air than ever. And how do we begin to both measure and understand and then implement new ideas around health information technology? So this is a brand new grant that we have to understand how we can measure sort of complex concepts like trust and equity and accountability, and even sort of our core bioethical principles. What does autonomy mean? And how can we measure it? And how are those related to both how people, what expected benefit is and how people are comfortable with AI? Oh, that is exciting.
What did you do?
I don't know.
I broke it.
This is where you were. Say, I think I was a couple more before. That's the last one. I want to say 46. 47. Yeah, you were there. Okay, there we are. So we've got, there's a lot of research and sort of studies to be done with the public. We also talked a little bit earlier about the idea that there are multiple stakeholders in this environment, and how can we provide the right tools to the people that are building the systems and healthcare systems. And so we're playing around with the idea of maturity models, which for the health informatics folks who are here are basically, they're used for software development, but they're also used for organizational development. And you can basically try to lay out a roadmap for what is where you would like to be and where you are now. Turning the sort of issue of trust hasn't died at all in the last 10 or 15 years. And how do you begin to, once you sort of identify that trust is not where you want it to be, how do you build trust and address the issue that our systems are becoming really too big to care? So even a healthcare system that may be doing the right thing, clinicians that are doing the right thing, maybe working in the context of a system that has predatory billing practices, or is going after people in ways that undermines the doctor-patient relationship. And find ways in which we can ultimately trust the public. I think every time we do public deliberation or we do surveys or something else, it's not a question of whether the public doesn't know enough. They're actually very smart about most of these things. They actually know a lot more about AI than we give them credit for. And when we assume people panic, it tends to undermine the trust that we're trying to build with them. We're looking at, this is a multi collaborative kind of thing. Am I? I'm trailing. I'm almost done. I think that's I'm literally trailing off. All right. So it's a collaborative effort, ultimately to build a better system than the one we have now, to both address sort of the structural inequities, inclusion of diversity, and working to sort of develop the capacity to have those human alternatives that we think we want to have through engagement infrastructure. And one of the things I like about this process of sort of surveys and public deliberation and follow-up is that we can, beyond questions of informatics, to almost any sort of major issue facing us today. That's it.
Thank you. Yes, some of it's virtual. Why don't let's stop the slides. And I think, while chat's available, we actually are all here. And so if anyone has a question or a comment, please just speak up. And while you're framing those questions, let me ask, the literature on what the people in industry and government and academia, we all say we're doing this for the benefit of our communities, for publics, for the, for people. And I believe that we actually are. When we've surveyed them about the use of information, your work here is really important to advance in that, because the last stuff was not as nimble as what I see you trying to ask. How big a distinction do you see in the public perception of the science between and among product development and on the one hand, broadly speaking, and treatment interventions, but on the other hand, public health and public health interventions? And COVID may be a good, because at the end of the day, the public health department is not going to be able to commodify the tools that it develops. And should I trust a health department more than the pharmaceutical company or the university or the government?
Yeah, so let me see if I understand your question. You're asking whether people differentiate between those different things?
In terms of concern about the use of their data, I would be tempted to argue that if the University of Miami is doing a project for the sake of an epidemiologic assay,
yes,
that's the sort of thing where if you demand, well, public health would collapse if we demanded consent from everybody who had a next case of flu or HIV. We presume a whole lot of consent for the basic function of public health. How much of that can we presume, given what you've learned?
Yeah, I think so. I think there's a fair amount of it that you can mostly presume. Like people want, and we've done some COVID studies, and people like, they're okay. They understand we need data, and we need to understand. We need to do contact tracing, and we need to talk to people about what's going on in their communities. But what they don't like is feeling like they're in the dark about it, right? So that's where it falls down. And I also think with the relationship with commercial companies, people get it. Like they know we're in this where we live. Like it's not a mystery that our healthcare system is totally fragmented and largely private. So they get it. But they also don't like the idea that it's a secret.
But it's very difficult to differentiate who is going to own your data.
Right.
I don't know if any of you had that experience that you go for a lab work.
Yeah.
Are you all able to hear the questions from the table online? Okay, thank you.
You are going for a lab work, and the person behind the window is asking you to sign what they call a consent.
Yeah.
And the consent is a small window in which you are signing. So that's a personal experience. I say, okay, I would like to know what I'm consenting for. And I really upset the person because a lot of people say, well, I will print this out for you after you leave.
That is not, by the way, if anybody hears from the risk management officer, general counsel's office, the University of Miami, we're gonna make a note of that and pin that for later. We have I hope it's okay to say this, and it's not unique to our institution. We have fetishized the documentation of consent over an informed consent process.
Yeah.
And I don't think that's unique, but it's Dr. Bookman, I see I detected your mental hand up.
Gosh, you're such a good mind reader, Ken. Dr. Platt, first, thanks. It was super interesting and relevant to any number of things that I'm also thinking about working on. And I'm sorry that I missed the intro, so you may have covered this. In the survey work that you have done, have you been able to also capture information about the payer? Because I would be really interested, and maybe we can discuss this offline, segmenting by Medicare versus, which is more more senior, Medicaid, which is low income, and commercial, which is a mix. Have you had a chance to tease things apart based on the identification of the payer?
No, but it's a good question and most likely a relevant one. I think that we do look at the data by like age and other, and whether people have insurance at all. And the demographics can be a little like, so there's more work to be done there, and people don't trust insurance companies, period.
Yeah, but is the data, in other words, did you capture the data, but you haven't analyzed it based on payer, or did you not even capture the payer information when you were doing the surveys?
So we've done this survey about 4 or 5 times, and I feel like sometimes we do and sometimes we don't. And I just don't remember through the last iteration of whether we got.
Okay, consider yourself urged to include it going forward.
Okay,
The second thing that I wanted to bring up for your response, as you know, I'm sure better than me, patients, we humans, people, have different sensitivities about different types of information. Thus, mental health information sharing may be viewed very differently from blood pressure information sharing.
yeah.
So I'm particularly concerned and would love to hear your thoughts about, a growing push for our health system to take into account social determinants of health, concerned that CMS is pushing this SDOH screening when we really don't know very much about all of the individual sensitivities around even capturing SDOH information. And so that in the sort of extreme case, I can imagine needing to consent for every individual health measure that I want to capture from a patient. And then consent management simply becomes impossible. Your thoughts?
Yeah, so I think there's two. So we do have data on a PhD student of mine is going to finish any minute now, but she asked, it's the same survey. So around what types of data was acceptable, or do people feel comfortable having part of sort of the predictive modeling AI world? And we included about 15 different things, ranging from like clinical measures to the sort of standard demographic, age, race, sex, and then some of these social determinants things as well. So income, history of incarceration, maybe education is one of those somewhere in between kind
Right.
of. And
Housing, nutrition, etc.
yeah, I mean, we didn't include all. I mean, there's so many, like to your point, like there's a lot of different data types that can go into models, but it did tend to break down much in the way that you just described, where clinical measures are okay, blood pressure fine, cancer diagnosis fine, even the sort of mental health things were kind of okay. Like it made sense, right, that you would have information about your health. The demographics were somewhere in between, which is also kind of interesting, and people are severely uncomfortable with all of those social determinants of health information. And there's zero rules about those kinds of data. Like they're very health data. So yes, there's certainly reason to be concerned. And it is complicated when you're trying to implement consent on like a million different measures and a million different users. And it's not really honest to say we're going to have informed consent. That model isn't going to work. And and so I don't know, like I wish I did, but how do you sort of protect the respect for persons that you're trying to implement that's consent at one point was trying to embody, and I don't know what it is, but we'll get there.
Very interesting, and not what I would have guessed that in your work, de-identified EHR data is as sensitive to patients as identified genetic. That was very surprising, and I'm a clinician. I collect a bunch of electronic patient-reported outcome data, symptoms, but also needs. In palliative care, we're collecting medication, financial needs. So, what might be viewed as very sensitive. And then I, as a clinician, I'm looking at this and making decisions about the patient. I also could and probably will, and as development of models gets much easier, a lot of people will be doing probably half-baked machine learning models where the computer is going to do a better job of looking and saying, guess what, this patient with this need. I'm not consenting the patients that I'm going to look at your data to make a decision. And even really that I'm going to develop patterns by looking at a group of patient data, just using my clinical judgment to look at patterns and say, oh, you know what, I'm noticing this among all these patients with this thing going on.
Yeah.
But then if I train a computer to do it, it seems like that, at least from your data, that an AI EHR de-identified thing would be something they would want to be notified about in the portal and or maybe consented for, which, and I don't know how we get there. And,
Yeah.
and is it how different it is, the computer model doing this versus me doing it? And I don't think for, however long we've had access to large paper records, patients have been doing pattern recognition in those things.
Right. Yeah, I mean, I think part of it is that that the technology is opening up a moment where it's like, okay, well, we can actually ask. It's a time to ask, right? It gives us an inflection, a reason to sort of say, maybe what should we be doing here? And I think that, I don't, the best I can do so far is sort of say, okay, we can at least try to make better moments of transparency, right? Which is even true. I mean, if you think about the doctor-patient relationship, the sort of, in some ways, the notion of sort of shared decision-making was a human way of sort of showing how your brain is working, right? And why you're making some set of recommendations and involving the patient in that. So we kind of need shared decision-making, but with the AI tool somehow.
Yeah,
I don't know what that looks like in real life, but that's, I think in some ways, the corollary.
Could we thread those two thoughts together? We'll call this the Bookman-Huber conjecture. How fine-grained when it comes to information that people are worried about do we need to? Well, we failed years ago when it came to if you recall, the debate over genetic exceptionalism and behavioral exceptionalism and HIV and STI exceptionalism. And the initial thought was, does that a particular malady might be more or less stigmatizing than another, is that a problem to be solved or something to be embraced? And I don't detect a whole lot of progress in the last 30 years on reducing the stigma of any of those things, which is a problem perhaps for the science here. And the idea that if we're going to be communicating, we will improve communication between clinicians and patients, but what a shame it is to lose all the data in the process. And depending on how we can store it, and I mean, Richard's point about payers is a really interesting point. In a country with a what's the word, Sergio? A dysfunctional healthcare system. All of these problems are lensed, and so the agenda for the world is how to make it so the shared decision making process is nimble, fine-grained, well-informed, without upsetting anybody unnecessarily, including people who are just inclined to be upset no matter what.
Yeah.
Which is often patients.
Right.
So, Dr. Platt, I'm curious if you have had a chance to look at how some of these issues are handled in sort of national single payer system like NHS in the UK, for example.
This issue being AI or data sharing or?
No, the issues around, consent for data sharing to support not just AI, but for clinical decision making.
Yeah, so there's more that I need that to be done here, and Ken, you might know more about some of the newer sort of WHO AI work that's coming out now. But in general, I mean, if you think about there's the privacy perspective. Europe passed the GDPR, right? That makes us all sort of click on those stupid cookie things on our websites.
Right.
So, but also it's making an attempt at really sort of turning, the notion of, notification and human alternatives and the opportunities to opt out a part of the fabric of how we have health information. I'm not sure that they did it. That's the way we don't want to go, but it's an attempt in ways that we haven't begun to attempt. California, in the United States, it's sort of a state by state. So California is a lot more advanced in sort of how they're thinking about privacy, and all of these things again sort of treat health as an exception, right? So this applies to everything except health, and at some point, health may need to be a piece of it. But you may want to comment on the WHO work.
Well, the GDPR, I mean, in part, Richard, the question is, how much privacy do ordinary people require if they know what a limitation on data sharing might do for public health? And so the GDPR, first of all, everybody in the United States wants European data and vice versa. We are now being, in many respects, governed by GDPR. Not just online. I mean, and so the challenge is the WHO struggled mightily to basically, the language is far too coarsely grained. It's grand, it's privacy matters, respect people. The point at which we really need to be able to assess this to improve the health of, in a learning healthcare system, right? I mean, the origin of this, remember, is there's all of Dr. Huber's encounters generate data. And the insight from people studying learning healthcare systems is what a shame that we're not able to use that. And so does the GDPR, Richard, impede that or improve it? And that's the example for a really good study in the future. Let's see what Health Canada says as opposed to the NHS. By the way, the NHS is a bit of a tight spot because they're already sort of committed to GDPR in Britain. But we've got 4 or 5 health models, and they're all, the questions you're asking have not, to the best of my knowledge, not been adequately answered anywhere. And then you throw in the United States with a payer system that we have, and everything goes sideways.
Yeah, I mean, I'm a pure guess, which makes it perilously close to BS. That most of the folks I know that live and work in the UK are, generally speaking, pretty happy with NHS. A lot of them actually have quite good experiences, and in that sense, those good experiences create a foundation of public trust in the NHS, a sense of ownership in the NHS, and therefore probably an increased willingness to share data with the NHS if it will help the NHS be more effective and efficient and better use its resources. So, I think one of the problems we face with our dysfunctional healthcare system in the US, particularly in the last 10 years, is the erosion of public trust in anything. So that's another part of the uphill struggle for you, Dr. Platt.
Thanks.
Can you solve that problem?
I'll talk to you next week.
Yeah, maybe by dinner, okay? Yeah.
Got it. Yep, no problem.
Mind you, it's also gotten worse for, by the way, the NHS enjoys it, and certainly enjoys a great deal of trust, but if you see what's happening over the last couple of months, the NHS is in real crisis right now. And people are still loving it and are upset, and they blame it on outside forces. Americans, we know, trust their individual physicians and distrust insurance companies in the system. And it varies by point of contact. I mean, Sergio's experience, and this is a common thing. You have not made consent part of my interaction with my doctor or the scientists I expect to come up with better treatment. You've gotten in the business of collecting souvenir signatures, which make me think you've got an agenda other than the one that was, which is not to fault the institution, because they're freaking out about someone saying you did not document that consent. It's a point to address. It's easy, but it comes at a somewhat higher cost.
Yeah, I think the other piece here that may help us sort of find a little bit of a pathway forward is this idea of having sort of diversity of opinion in the decision making and the policy making process, right? So we have done surveys where we say so one of the fundamental sort of ethical sort of justifications for the learning health system is that people have a moral obligation to contribute their data because we're going to learn things from it and do good. So we put that out in the public and said, do people have an obligation to participate in research? And they said no. And and the people who said no were the least comfortable, and that's the least able to trust, right? But the people who are making those calls about this is going to be a learning healthcare system and all the patients have to participate are the ones who really believe that fervently and with all of their heart and with all of their best intentions. And so just having those people in the same room with somebody that's like, no, then there may be some kind of a bridge that can be build, and you can begin to have that sort of collaborative win-win kind of situation. And in the UK, like when the NHS tries to do something that the public isn't okay with, they ran into this with like the UK Biobank, it's the data.info thing. There's a public outcry and they stop, right? And they figure out a new program to build around it, which you can do in a little tiny country with you can integrate with a single healthcare system. But that's maybe sort of what you see outside of the US and that we can learn from.
I'm going to take that as a positive and forward-looking conclusion. I want to have a special thanks to our colleagues. I see Jacqueline Green, Nick Centeramus from the Institute for Data Science. Thank you very much for being here and for your encouraging support. Dr. Bookman, thank you very much for being here. I'm on a big screen. I can't see who else is here, but if you're here, thank you. Join me all, please, in thanking Dr. Platt for a fabulous presentation. See you in the next dialogue, which will be 207. Looking forward to seeing you in the future. Thank you.